Another picture of a sphincter damage, as you see going up here, and notice that Valsky shows us that the external sphincter may look a little bit thicker right where it is when we have a tear here in the internal, that you can get thinning of that internal there, and you can get thickening on the opposite side of the rupture. They called it the half moon sign. And then once again, the mucosal star is abnormal here. Now, when you do thick slice imaging, the left-hand column here, these are all normal. The right-hand column here are all abnormal. It ends up that it's not so hard to decide that it looks normal to you. It's these abnormals that you don't know exactly what's abnormal. Is it just the internal? Is it the internal and the external? Here you have the entire rectum is a very thin little bit of internal sphincter. And here again, you have it being pulled up anteriorly. And so there's clearly an internal tear. Is there an external tear? You'd have to go up and down to make that decision. But just like ultrasound in other places, there's lots of artifacts, and just by tipping it a little bit, you make it look abnormal. But notice that the mucosal star is not really being pulled up here. And when you just rotate your transducer a little bit, you see that it's really totally normal. Now, when you look at this anatomic diagram of the anal canal, I think it's important to realize that the pupil rectalis is closer to the anal angle, and that the external sphincter is closer to the verge, and the internal sphincter overlaps the two other muscles. So when you look at multi-slice going through these, that's an important thing to know. Now, the technique for the pelvic floor is a little bit different. Before we tip downward, now we tip outward. And we take a high-frequency probe and we place it on the perineum, and we acquire volumes that we can see the symphysis pubis anteriorly and the anal canal and rectum posteriorly. Here's another diagram of the pelvic hiatus. It's not quite perfect, but it's reasonable that we have this pupil rectalis muscle coming up to the region of the symphysis pubis and fanning out with its muscle fibers. It's not one little point. It's along the entire part of the pelvis. Notice again the urethra, the vagina, and the rectum. So here is the transperineal view, or the urogenital hiatus as it's been called, and you can see the pupil rectalis muscle, you can see the urethra, the vagina, and the anal canal. And this is a diagram that I think helps you just go along and follow that. Now, I think this MR diagram is very nice to show you that this pupil rectalis muscle, what it looks like here, and that it's right off the edge again. And then when you correlate with the 3D and you get the planar information, here's the pupil rectalis very nicely with the symphysis pubis up here, and then the urethra, the vagina, and the rectum. And then when we do that thick slice or narrow volume view, you can see the pupil rectalis muscles coming out, anal canal, vagina, and the urethra. This is how you do it. You acquire a sagittal, and then you rotate this box C so that it's upright. Then you move the cursor up to where you think the symphysis pubis is going to be here, so that here is our symphysis pubis, and then we rotate it on that dot so that the cursor is on the symphysis pubis over here, and we rotate it so that we can get that in one plane. That plane is very important. I'm going to go back and show you that clip much more slowly now that you have the concept, so that you can see how to do it yourself. Okay, so first you acquire in the sagittal plane right here. So here's the anal canal, here's the rectum. The symphysis pubis has to be over here in the left part of the image. So we went back and forth till we could see it. Then we have our angle coming right down the region of where the vagina is going to be. So we've swept it. Now we're going to zoom just a little bit. Box C, we're going to rotate it up so that we're going to get that pelvic hiatus view. Okay, so now we're there. Now we're going to watch this dot. We're going to move that dot until it goes up. And now as we're moving it up here, we're looking in box A, and we're seeing until we get the symphysis pubis. Now we are in the symphysis pubis right here. There's the symphysis pubis. So now we're going to move the cursor in that plane from here up so that we know where, exactly where the, there you go, we grab it, we move it up to the tip of where the symphysis is. That is the tip of the symphysis pubis, and that is the same in all three planes. So it's right over here, and it's right down here. So now we have this here, and we need to rotate box B so that it is parallel so we can get this angle. So watch, now we're going to rotate it like a record player in the Z-axis. There we go. Because now we are in this plane with the angle is right here with the cursor from the symphysis pubis located from box A. Now I know that you can replay that on your tapes or whatever, but the idea is now we have a perfectly reproducible plane that everyone across the world is using to make our decisions about this. So when you think of it, the yellow line is the urethra, the pink is the vagina, and the orange is the anal canal. Okay? And this is the angle we're looking for. We're looking for the symphysis pubis to the to the anal angle right there, anal canal angle. And then if we put these measurements on, here is the vagina again, here is the anal canal, and here's the urethra. Now we did measurements in our research measuring areas, perimeters, all types of things, volumes, but what panned out is the best is the anterior posterior length of the hiatus, and it actually is very simple. There we go from the symphysis pubis where we put that dot to the anterior part of the puborectalis, and we do it with rest and we do it with squeeze. And you tend to be able to make your calls of your abnormals best on your squeeze images. So here are some pictures of a scoring of what was developed for MRI, and we're using it with ultrasound as well. And this is a normal pelvic hiatus. We count it as 0 because it's normal. Nice normal here. Here's another, just a little different, nice normal puborectalis muscle. Here on this image, this side looks normal, but this side just looks a little asymmetric and it doesn't look as tight. This one looks thinner on this side. So we got a score of 1. This one scored a 2 because you just really can't quite see it. And this one scores a 2 on both sides as well because of the, we can't see that puborectalis very well. Asymmetry is important when you're looking at these in order to help you make the differential. Now, the shape of the vagina is also something that we became aware of. We put a balloon in and we increased it with different sizes just to see what the area looked like. And you might think, well, this is really just research, and indeed it is, but look at this clip. Really helped us understand what was happening. This is the vagina filled a balloon in the vagina. Here's the symphysis pubis over here, and here is our anal canal with our anal rectal angle right here. That is why we want the line to go from the symphysis to the angle, because that's where we contract when we do that squeeze mechanism. Now, MRI has been used to look at the pelvic floor at rest and at squeeze, and you can see the diameter changes, the same angle changes, and we know that on MRI that the pelvic floor is moving in multiple directions. It's not just a simple vertical direction or in an anterior posterior direction, but indeed it is a vector. It goes up in a vector type position, and we've been trying to figure out how to measure that. But the rectum and the whole buttocks moves when you squeeze, so you can't keep in the same direction.